This is describing a couple of things, really, from what I can tell from the presentation. It's describing the Better Start National Science Challenge, which myself and Sheree and Nicola and various other people are involved with. It's describing two analyses that we've done from that as part of the big data theme of the Better Start National Science Challenge. And then to finish off, there's pros and cons of the IDI, couple of slides. So I'll do my best here. We'll talk a little bit about Better Start and what the big data theme does. Talk about two projects that we've been working on. The first one, looking at the association between antibiotics and obesity. One of the main outcomes that we've been looking at in the Better Start National Science Challenge is obesity. We've got a preschool measure of obesity in New Zealand, and it's more or less the only nationwide measure of obesity at any age that you have. And then another interesting one, that project involves Sheree, led actually by Wayne Cutfield and Karen Leong at the Liggins Institute, but Sheree and a colleague, Jessica McClay, did a lot of the analyses for that. The second one has been led by Sheree, looking at, well, the before school check is a nationwide screen of 4-year-olds. What's its level of coverage? So what people are missing out on the before school check. I know this is parallel some work that Growing Up in New Zealand doing in the same area. And then a little bit of talk about the IDI advantages and challenges. National Science Challenges, these were announced 4 years ago, I guess it was now, and each of them now are coming towards the end of their first tranche, they call it, and deciding what they're going to do for their second tranche of funding. First must have been 3 years in the end, actually, and the second is going to be 6 years. 11 challenges across different science areas, directly funded by the Ministry of Business, Innovation and Employment. 3 health challenges more or less chunk up the life. So we've got Better Start going from before birth to about age 25, and then Healthier Lives, touching on some of the stuff that Rod presented before, going through the mid part of life, and then Aging Well, talking about the last part of life. Better Start, as I mentioned, one of the main outcomes we've looked at is obesity. We've got 3 themes and one overarching group that works with those themes. Healthy weight, so the focus there, as I say, is on measures of obesity. We've done a lot of work really with the before school check and its measure of obesity. Successful literacy and learning, about educational development through the early part of life and then through high school and into employment thereafter. Resilient teens. That theme has been focused a lot on adolescence and some fancy apps that they've developed to help teens with depression and other mental health problems. And we, as part of the big data theme, that's myself, Rick Ordis, Barry Taylor from Otago, and a few other people, Nick from Otago, Nicola here, Sheree in Wellington. We work largely with the whole population administrative data, which I'll describe shortly, but have been spoken about a bit today with the IDI, to work with these challenges to answer questions that are of interest to them, and also we come up with our own questions that can be answered with the data. This is the data resource that we use for the most part, the integrated data infrastructure. What you've got there is a person-centred data resource where interactions with government sectors, as has been pointed out, mostly for negative things, are linked together at the individual level. So you know that the person who was born with this birth weight had a level of BMI at age 4 that was this, went on to school and had these interventions at school, perhaps had interventions of SIFs, left school, became unemployed and so touched the benefit system, then got employed, touched the tax system, etc., all linked together at the individual level. So not just New Zealand, anyone who contacts those systems would be in the IDI. So if you are flitting through the country on your way out, but you happen to touch one of these systems, the health system, for instance, you'll be in there. And as I say, it allows us to connect information about a person across different sectors. And the way it works is there's this thing called the IDI spine. And what the spine is a triangulation of births, tax records, and in-migration and out-migration records. So if you're in one of those 3, if you touch one of those 3 areas, you're in the IDI spine, and that's a long list of people who are in the IDI spine. All the other data sets are linked to that spine. So if for whatever reason you're not in the spine, and there's various reasons why that might happen, but you do have records in health, for instance, or in the benefit system, you can't link across those other sectors, okay? So you have to link through the spine. And for our purposes in the Better Start National Science Challenge, we use the before school check a lot. That's what certainly our group at Compass has been working mostly on that. Hospitals and prescription data we're starting to work with. 2013 census data. Some data on secondary mental health services, so that's community outpatient mental health services, and then other various bits and pieces on demography and geographic location, like the width of Dan and Fran talked about. Managed by Stats New Zealand, approved users only, so you apply to use a certain chunk of the IDI in an application. They assess your application, that it's for a public good research project. They assess you, you do some training, then at that point they grant you access in a secure environment called a data lab, and you have at that point access to analyse data, but you can't take it away from there. If you want anything from there, you run some analyses to get results in the forms of tables or regression coefficients or what have you. You ask for those to be released. There's various confidentialisation that you have to apply to that, and then at that point it's released. Okay, that's all by way of background. We'll talk a little bit about a couple of the Better Start projects that I mentioned before, the antibiotics and obesity and an assessment of who's getting the before school check. This is another thing that you learn when you become an IDI user. You have to put a disclaimer every time you show the data. They're saying it's our work, not Stats New Zealand, and the data was provided in the secure environment that I just described. So this is a project driven by Karen Leung and Wayne Cutfield at the Liggins Institute, wondering whether there's an association between antibiotic use, both in childhood and in the mother of the child during pregnancy and later obesity. One thing you can do with the IDI is get some intergenerational links going there. So, this child was born to this mother, and by tracking her ID, you can look to see what medications she has used, such as antibiotics. So this is where we use antibiotics prescriptions from pharmaceutical data, height and weight from the before school check to get a measure of BMI and a WHO measure of obesity. And what we did is we used 4 years' worth of data, 4 years' worth of births from 2012 to 2015. The reason we started with those 4 years was that if you go back from there to when the child was born and the year prior to that during the pregnancy of the mother, it's at that point that you get to when the farm's records started to get good. Prior to mid-2006, I think, the farm's records weren't complete. So this is kind of the earliest cohort we could use if we want to look at age 4 obesity in relation to something that may have happened 5 years prior to that. When we looked at this, we adjusted associations for various factors such as birth weight, delivery mode, gestational diabetes, parity, gestational age, hyperemesis, multiple birth, etc., and demographic things, NZ depth, sex, ethnicity. The length of time the mother stayed in hospital is a measure of potentially how sick the child was. Birth month, rurality, and maternal age. And what you see there, what we've got here is looking at the child antibiotic use on the right and the maternal antibiotic use on the left. You see this lovely sort of linear pattern between the more times a mother has used antibiotics, the more likely the child is to be obese. This is based on WHO criteria. Significant associations there, dose-response associations, and if you, in the same model, which I might be getting to shortly, put the child use and the mother use in the same model, they seem to be independent associations. So even controlling for how many antibiotics the mother used, the antibiotic use of the child will increase the risk of obesity and vice versa. I don't know too much about the biology here, but talking to people who do know a little bit about the biology, it seems that some of the infections that you would tend to get antibiotics for don't in and of themselves raise risk of obesity. That's the claim anyway. So that's why we think it might be related to the antibiotic use itself, not the conditions that the antibiotics are being prescribed for. So antibiotic use in pregnancy and the first 2 years of life is associated with a small but significant increase in obesity. It is potentially important on a population level as antibiotic use in pregnancy and in infancy is widespread and is patterned by ethnicity and deprivation. So here we've got the prevalence of antibiotic use in children who are Pacific, Māori, Asian and European, and the prevalence of antibiotic use by NZ-DEP, which Dan described, so in quintiles here. And what we know also is these pattern obesity quite strongly, both ethnicity and deprivation. If you control for antibiotic use and you look at ethnic effects on obesity, they're largely unchanged. So it's not as if the antibiotic use is explaining much of the association between ethnicity and obesity. But nonetheless, it looks like that you could reduce, assuming this is causal, could reduce obesity slightly if there was a reduction in antibiotic use. Next, one thing, a paper Sheree's working up for publication at the moment actually, is around who receives the before-school check, because the whole idea of the before-school check is a monitoring progress in children prior to their entry in school. And to do that, ideally, what you want to be able to do is monitor all children, not just children who decide who are brought along, which may be patterned by various things. So the question is, are we missing out on any important groups of people who would otherwise like to get the before-school check? So the before-school check, as well as height and weight measurements, it's also got assessments of various other things. There's the lift the lip screening, which was talked about before, which is a dental health screening. There's an assessment of hearing and vision. There's a behavioural assessment, the Strengths and Difficulties questionnaire, answered by the mother and also by the preschool teacher of the child, although the response rate for that's lower. And there's also the PEDS, Parental Evaluation of Development Screen, I think, that the parent fills out about any problems that they note with their child. So these are broken into the vision and hearing checks. The things that are done on the nurse checks are the height and weight and the SDQ interview with the mother and the PEDS evaluation and the lift the lip as well. Overall, this is the number of children completing. And just as an aside here, what we used as a denominator here, which Rod touched on, was the methodology that Sheree and Sunila and Jin Fong and others have created to create a denominator population for New Zealand. So which is different from what the Ministry of Health does in terms of contacting mothers of children for the before-school check. They use the PHO register. So if you're registered with a PHO, which most children, was it 96% of children are, you get contacted. But what they don't know about is that extra 4%. This is what the denominator that Sheree created gets you. When you look at it that way, in the 14-15 year, and it's gone up over time, there's around 91% get the vision and hearing check, 88% get the nurse checks, but far fewer get a response back from the teacher of the preschool teacher of the child to fill out the behavioural assessment from the Strengths and Difficulties questionnaire. And what you see is kind of mild but detectable. They'd look stronger if you flipped it the other way, those who didn't get it and had it sort of down this way. But an effective deprivation there. So whereas over 90% of those in the least deprived quintile get the vision and hearing assessment, it's around 86% of those in the most deprived quintile. The nurse checks, you see a similar response there. And other factors that were associated with not getting a before-school check are receipt of the family being on benefit, mother without educational qualifications, Pacific or Māori ethnicity, rented house, so very social determinants of health type things, low birth weight, smoking the mother, and having lots of prior hospital admissions. So a sicker child, or perhaps a child that's come to attention of services for other reasons. Concluding from this, not all children are receiving the before-school check. Many of the characteristics of children who miss a before-school check are associated with later life risks, that list I went through before. suggesting that the before school check may not be reaching the children who would benefit most from it. So we're talking 10 to 15% of children depending on the subgroup, but an important 10 to 15% of children. So, just some musings by Sheree and others on advantages of using the IDI. What we showed here is you can collect information across multiple sources. This one's a really good example of that, actually, the antibiotics and obesity, because it shows the intergenerational link that you can do with the linked data and then the linking to pharmaceutical records. Other things that I'll touch on shortly, actually, are in the justice area, and also mental health links that we're doing some work on. But, and here's something also alluded to, the data sets that are involved in the IDI all have different time frames. Okay, they all go through to now, more or less, or and when they're most recently sent through to Stats New Zealand a year ago or so. But they start at different times. So if we go to the health ones here, so the before school checks started around late 2008, one full fiscal year, 9-10, but it was low coverage. Really, it gets good from about 2010. The farm record's good from about 2006. Hospitalization's good from about 1988. Education from the mid-90s. Benefits from about 1992. And criminal convictions good for, or available from about 1994. Birth records from 1848, which was when the Birth, Deaths and Marriages Act came in New Zealand, I think, and you had to register a birth and a death and a marriage.
Mortality, is it 1848?
Yeah, well, it's 1848 it should be. So yeah, I mentioned that we can link children to their parents to get information about parent characteristics, smoking age, income, but also other things that have happened to the parents, such as their pharmaceutical use. We've done this through birth records, so possible for New Zealand-born children only. There's other ways you can get parental links, for instance, through the census, but not as thorough, I don't think. Just some challenges here, and I would concur with these. The majority of project time has been understanding the data, getting access to the data to start with, understanding the data, investigating quality problems, of which there are quite a few and they're not particularly well documented. The documentation itself far lags behind the availability of the data. So there's some things that has very patchy documentation, others none at all. And I think there's a lot of work that can and should be done around understanding linkage errors and bias. It's all based on probabilistic linking there to the spine there. And the spine itself is based on linking. Depending on the data set, there can be lots of missing data. Going back a way, the immunisation records, for instance, have quite a bit of missing data. And there's this problem of inferring that something hasn't happened because the event isn't in there. And it may not be in there because it didn't happen, or there's been a bad linkage, or it hasn't been recorded, or what have you. So there's that you always have to keep in mind. It is administrative data, so there's various things that aren't included in there. You don't get the soft measures on well-being or diagnostic assessments of mental health that you would other get from surveys. So I think surveys and other collections still have a valuable role to play. As was mentioned by Andrew, there are some measures of importance to Māori, the tikupinga being a classic example. The census has iwi information, but it's incomplete, and the linkage and Māori participation in the census is lower. And one big missing, and this is where Rod has done a fantastic job, is working with primary healthcare data. It's not currently in the IDI for various reasons to do with data quality on the one hand, and I think governance on the other hand. We certainly want to highlight these issues of data quality, and we see that as part of our role in the big data theme of the Better Start National Science Challenge. And we're pushing sort of lightly to see if we can get primary care data in there. There's some investigations of that now.